Welcome everyone to this session on child health at the IUSSP Population and Poverty Conference. Really glad you're able to join us. This is a second session that I'm chairing. The first one was my dry run at doing this virtual conference. So hopefully I'm getting a little bit better. My name is Kathleen Beagle. I'm a lead economist with the gender group at the World Bank, and I'm a committee member for the scientific committee for this conference. And we're really delighted to have you all here today and to go virtual. It was sad that we were not able to be in Paris, not least because Paris is a lovely place to visit, but also, you know, we obviously all the changes that have come with the crisis that have come with the pandemic, making it hard for all of us. So we appreciate your joining us, and we're really pleased to have three wonderful papers at this session. I'll just give a little bit of overview of how we'll run the session. We will have three papers presented in order. Then we will ask each of the authors will be discussing another paper in the session, so they will discuss that paper for a few minutes. We'll allow the authors to respond to those discussion points very briefly, and then we'll go to the Q&A and chat questions and comments that you put into the system as a participant. So we encourage you during the presentations to use the Q&A and chat or the chat feature to put in your questions, your reflections on the work. And we will follow the session with a Meet the Authors opportunity to have a more informal connection with the authors and other participants. So with that, I will take us into our first paper. So Tiago Bonomo is going to present on social protection in Brazil and the impact on infant health and pregnancy outcomes. Thanks.
Hello everyone, my name is Tiago Bonomo. I'm a UBC PhD student, and I'm going to present this joint work with Cecilia Machado from FGV in Rio. And in this paper, we are studying the effects of conditional cash transfers on birth outcomes, focusing on the case of the Bolsa Família program in Brazil. So there is this whole discussion on what is the best time for an intervention regarding health outcomes. And according to the fetal origins hypothesis, the in utero period, it's very important to determine future health outcomes. And the Bolsa Família program provides a very interesting setting because there was an expansion in November 2011, which introduced a specific transfer for pregnant women. And more importantly, we also have several very rich administrative data available that we are going to use it to try to answer this question. There is a rich literature studying the effects of in utero interventions on birth outcomes, but most of them, they focus on in-kind or cash transfers without exploring conditionalities. So this paper tries to add to this literature by studying the effects of the combination of both the cash transfer, but also the prenatal care, which is a conditionality to receive this transfer in the context of the Bolsa Família program. Just a quick preview of the results. We find large and monotonic effects according to the length of exposure during pregnancy. So for mothers who received 4 or more months during pregnancy, we find increasing birth weight, but more importantly, a very strong reduction in the incidence of low birth weight and also preterm births. We also find large effects on early prenatal care, although we don't find any effects on the total number of visits during pregnancy. And we also look at other birth outcomes, but we don't find any significant effects. So just a quick overview. The Bolsa Família program was created in 2003, focused on extremely poor families and poor families with children in the household. So it's the largest cash transfer program in the world, and in its design, we have 2 types of benefits. The first one is a basic benefit for extremely poor families without any conditionality. The second one it consists of variable benefits for poor families with children and youth in the household. And there was a maximum amount of 3 benefits per family, and they are conditional on school attendance and health monitoring. So in the end of 2011, they introduced the transfer for pregnant women, which is called the BVG. And so they also increased the maximum amount of benefits per family from 3 to 5. And one important feature of the BVG is that it has priority over the other variable benefits. So they increased the total amount of benefits and they gave priority of the BVG. So this means that basically all eligible pregnant women, they should start to receive immediately after its introduction. So the BVG, a key feature of the BVG that we are going to explore in our empirical strategy is that it consists of 9 monthly payments, which starts to be paid when the woman is identified as pregnant. And this is regardless of the stage of pregnancy. So this means that mothers in different stages of pregnancy, although they would receive 9 monthly payments in the end, so the total income, it's going to be the same, they are going to be differently exposed to the benefit before giving birth. So just a quick example, one woman with 3 months of pregnancy, she would receive 6 months before giving birth and 3 months after. On the other hand, a woman with 6 months of pregnancy, she would receive 3 months before and 6 months after giving birth. So we are going to explore this in our empirical strategy. And the conditionality to receive the BVG is prenatal care. So there is a high incentive for the first visit because that's when the women are going to be identified as pregnancy and starts to receive the benefits. On the other hand, the incentive is lower for future visits because this compliance is checked only every 6 months. So we use 3 types of data. The first one is the CAGI Único or Unified Registry. So it contains information, individual and family characteristics of all Bolsa Família beneficiaries. We also use the Bolsa Família payroll data, which we have information month by month of all transfers, including type of transfer and the amount of transfer for all beneficiaries. So in the payroll data, we can identify pregnant women that are receiving the BVG. And finally, for the health outcomes, we use the vital statistics system for Brazil, which contain birth outcomes and also some characteristics of mothers for all registered births in the country. So let me just explain quickly how we constructed our sample. So we start with a sample of all pregnant women that started to receive the benefit right after its introduction. So we have 23,700 women. So as I said, they receive the highest priority at the moment. So indeed, most of them started to receive the benefit right after its implementation. And also gestational age, it is exogenous at the time of the implementation. One disadvantage is that some women will only be aware of pregnancy later on. But we deal with this. We also run the results using an augmented sample, and the results are pretty similar. So we need to match these pregnant women with their children. So we go to the Unified Registry for future years, and we restrict to the births that happen in the window that it's correlated with the transfer. So from December 2011 to September 2012, which means no more than 9 months after the transfer. And finally, we have to match them with the birth outcomes. Unfortunately, we don't have individual identification in the vital statistics data, but we use the mother and the child's date of birth, the gender of the child, and municipality of residence to link the 2 types of data. And we end up with a sample of 6,749 births. So here's our baseline specification. So the BVG are our treatment. So this means 1 month of exposure during pregnancy, 2 months of exposure, 3 months, and 4 or more months, which is our main treatment. And the omitted category here, it's our control group, which are mothers that received less than 1 month of the benefit before giving birth. So we first check if there are significant and potentially harmful differences between the treatment and control groups, which could undermine our results, but doesn't seem to be the case. And for the main results, I will ask you to focus on this line here, 4 or more months. So mothers that were exposed during the full last trimester. And we find a positive effect on birth weight, and especially a strong reduction in the incidence of low birth weight. We also find a strong reduction in the incidence of preterm births, but for the other outcomes, we don't find any significant results. Finally, for prenatal care, although we don't find any effects on the total number of visits, we find a reduction in the month which the mother started the prenatal care, and correspondingly, a reduction in the percentage of delayed prenatal care, which is after the 3rd month of pregnancy. So a couple of challenges here. The first one is the pregnancy awareness. So we use this augmented sample using all women that received the BVG and had births no more than 9 months after they started to receive it. So we have a much bigger sample, and the results, they remain similar and even stronger. We also look at trends in birth outcomes. So we conduct an event study, and we don't find any evidence of pretrends and sazonalities. Finally, we have this sample selection problem, and here your feedback would be very great because we don't have the person identification in the vital statistics, so we need to match mothers with children using the Bolsa Familia data to get the dates of births, and we lose a couple of observations here. So this is something that we are trying to improve, and your feedback will be very important. So to end up, I would like to stress that the results that we find regarding birth weights, they are downward biased because of surviving fetus. So it could be the case that less children are being born dead, but at the same time, they are born with lower birth weight. So this would bias our results toward a zero or a negative effect. But we find a positive and significant effect. So I would like to stress that the effects are a lower bound. And just to wrap up, because I'm getting out of time, I would like to stress that in the case of Bolsa Familia in Brazil, we find a strong evidence that in utero interventions of conditional cash transfer programs, they are responsible for large improvements in birth outcomes. And here we can see that the timing of the cash is very important, but also the conditionality, in our case, the prenatal care, seems to be a very important mechanism for these results. So unfortunately, I'm running out of time, and there are much more results that I could show you. Everything is in the paper, and it would be great to have a discussion after the conference. So thank you very much for everything, and it's a pleasure to participate in the conference. Bye-bye.
Super. Thank you, Tiago. Now we will move to our second paper, which is going to take us to Senegal, and Hamadou will be presenting on the impact of rainfall and infant mortality. Thank you, Hamadou.
Hi, everybody. My name is Amidou Diallo. I am a PhD student at Dauphine University, and I'm so pleased to attend this session and present this paper on rainfall and infant mortality in rural Senegal. So now I'm going to present the motivation of this paper. So the climate scientists predict that rainfall variability in Sahel will be more frequent because of climate change. And the most likely future scenario is a drier in West Sahel and wetter in Central Sahel. And here this graph shows that the amount of rainfall on the amount of rainfall will decrease in West Sahel and increase in Central Sahel. So the changes in the rainfall patterns could adversely affect the health outcome in low-income countries, especially in Sahel, where rural households rely on rain-fed agriculture. And also, few studies analyze the link between rainfall and infant mortality using causes of death data, and the different channels at work are not well understood. So here in this paper, we examine 3 questions. So the first one is, do rainfall affect the postneonatal and child mortality? And the second one is that are the effects of rainfall heterogeneous between girls and boys? And then we will try to better understand how we can explain this effect. Is it a disease and environment effect, or is it an income and nutrition effect? So the disease and environment effect means that higher rainfall may increase mosquito breeding, and also raise infant mortality caused by malaria. And the income and nutrition effect means that higher rainfall may increase the agriculture outputs and also the household consumption, which could improve health outcome and also lower infant mortality. So in this paper, the contribution is a threefold. First, we use a high quality demographic data over a long very time span between 1985 to 2016. And then we analyze the impact of rainfall on infant mortality between 1985 to 2016. And the last one is that we use the causes of death data to deeply understand the different channels at work. Is it the disease environment effect, or is it an income and nutrition effect? So in this paper, the study area is the Niakhar Health and Demographic Surveillance System, which is the oldest in Africa, started in 1962 and located in rural Senegal. So this map shows the study area and also the rain station. So we have 30 villages and also 2 communes. So in the Niakhar area, birth, death, and also migration have been recorded yearly since 1962. So which is a long-term panel, in an African context. This graph shows the evolution of the postneonatal and child mortality rate between 1985 to 2016. And here we see that the mortality rate declined between this period, and also we see a peak of mortality in 1985 and also 1998 and 1999 because of meals outbreaks. So now I'm going to explain the different channels through which rainfall may affect health outcome and also infant mortality. So the first one is the income and nutrition effect. So higher rainfall may increase agriculture outputs and also the household's consumption, which could improve the health outcomes and also lower the infant mortality rates. And KIMS has shown that increased rainfall may increase the opportunity cost of time of mothers in the rain season, which could reduce breastfeeding and also may increase infant mortality. So the second channel through which rainfall may affect health outcome and infant mortality is the disease environment effect. So higher rainfall may increase mosquito breeding and also infant mortality caused by malaria. And so on the other hand, on the other hand, higher rainfall may increase indoor cooking with coal and wood, which could increase the household air pollution and also infant mortality caused by respiratory disease. So overall, the results are mixed and context dependent. In this paper, we use demographic and causes of death data from the Nyahar Health and Demographic Surveillance System between 1985 to 2016. So the causes of death data come from a verbal autopsy. For each death recorded in this rural area, the surveyors ask a number of questions to shed light on the specific symptoms leading to death. Then two doctors will examine the questionnaire and also give a likely cause of death. And after that, we compute the post-neonatal and the child mortality rate. Then we compute the outcome at the village level from June to May, and also from June to October, which is the rainy season, and also from November to May, which is the dry season. In this paper, the rainfall data come from the service départemental pour le développement rural, which is a service of the Agriculture Ministry, and the data contain the monthly rainfall recorded in the rainy season from June to October between 1985 and 2016. And in this paper, we use two rainfall variables. So the first one is the level of rainfall, and the second one is the log rain deviation from the historical mean. So we use the level of rainfall to measure the average effect of rainfall on the mortality rate. And second, we use the log rain deviation to measure the impact of rainfall shocks on the mortality rate. We also use infrastructure data and also household good and equipment surveys. Now I'm going to present the econometric model. In this paper, we estimate Ils estimation model. And here, as you can see, the MR is the post-neonatal or the child mortality rate, and the rain CT is the level of rainfall or the log rain deviation. X is a vector of village level control, and also we also add a village fixed effect and a linear time trends. And here we see that the mortality rate declined between 1985 to 2016, and also the rainfall increased over time between 1985 to 2016. Okay. So now I'm going to present the result. So this table presents the impact of rainfall on post-neonatal mortality, and here we see that, and here we see that higher rainfall increase the post-neonatal mortality rate between June to May, and also between June and October, which is the rainy season, and here the result obtained with the level of rainfall and also the log of rain deviation are very similar. And this table shows the impact of rainfall on the outcome, which is the child mortality, but we find no impact of rainfall on the child mortality rates. So now we analyze the impact of rainfall on the post-neonatal mortality rate by gender. And here we find a strong gender effect. We find that only girls are sensitive to rainfall. We find that higher rainfall increase post-neonatal mortality rate only for girls, but not for boys. and this effect is very strong. Here, this table shows the impact of rainfall on child mortality for girls and also boys. But here we do not find. But here we find no significant effect of rainfall on the child mortality. So now we estimate the effect of rainfall on post-neonatal mortality by cause of deaths. And here we find that higher rainfall increased mortality rate caused by respiratory disease and also by malaria. And the effect is occurred in the rainy season from June to October. And here in this table, and we show that we show the impact of rainfall on the child mortality rate by cause of death. And here we see that higher rainfall increased child mortality rate caused by malaria, and the results are consistent with the disease environment effect. So overall, we find that higher rainfall increase post-neonatal mortality caused by malaria and also respiratory disease in the rainy season. We also find that increased rainfall seems to rise child mortality rate caused by malaria in the rainy season. And also we find a strong gender effect. Only girls are sensitive to higher rainfall. So the next step is to try to better understand the gender heterogeneity and why only girls are sensitive to rainfall. And also we will examine the heterogeneity of the effects of rainfall by the distance to the healthcare center and also the mosquito net use. So thank you so much for your attention.
Thank you, Hamadou. That was a great presentation. Now we're going to move to yet another setting. Pallavi is going to present her work on linkages between infrastructure and child health in India. Pallavi.
Hi, I'm Pallavi Panda, and I'm an assistant professor of economics at State University of New York, Geneseo. And today I'm going to present my research on the linkages between building road infrastructure and child health outcomes in India. Now, why I studied this topic is because a lack of access to the nearest market or health center, as we know, significantly constrains people's economic and social opportunities. And India is a specifically great example because in 2000, 40% of villages in India lacked an all-weather road. And this lack of access to road infrastructure can hamper economic development. There is a big literature looking at access to transportation infrastructure that can create increases in labor force participation rates. It can increase incomes, create access to a better variety of goods, affect trade. On the positive side and on the negative side may increase pollution or increase inequality. So there are different channels through which building transportation infrastructure can affect health. And so this paper is an empirical approach to it. Empirically, though, it is difficult to establish causality as road placement is likely to be endogenous to other socioeconomic factors which can also affect development. And I discuss two scenarios. One, a road infrastructure is not randomly built. It is a need-based allocation. So therefore, places that need roads will get those roads first. So since this is not a randomized allocation, it is difficult to establish causality. And second, it's not only a static decision, it's a dynamic decision where a placement of the road is a function of different time varying factors. So For example, it is possible that if the government sees a particular city to be developing in the future, it is going to invest more in the road infrastructure for that particular city. So to overcome this, literature uses instruments based on historical routes or from calculating straight line distance. What this paper instead does is it uses a quasi-random experiment of rollout of the roads under a big India-wide road building scheme called the Pradhan Mantri Gram Sadak Yojana, PMGSY. And based on the allocation of the road, I looked at the differential access to the roads by the villages at different points in time. So this program was targeted in mostly rural areas. So there is a host of papers discussing rural roads and health. So we see reduction in travel time and cost can lead to increase in use of formal healthcare. So people can access hospitals more, that may improve health. We can see that that may increase household per capita income or consumption. Again, that may be beneficial to household health. Community infrastructure like access to electricity, improved sanitation, and public health expenditure also has effects on child mortality. So infrastructure and child health are linked via these various routes. There is also this new literature on this particular scheme that I'm looking at, the Pradhan Mantri Gram Sadak Yojana, and there have been studies looking at education. So this great paper by Dukia et al. Finds that PMGSY leads to more education for children and better performance on standardized exams. Similar result is obtained by Agarwal, where there is an effect on schooling decisions and consumption. This newspaper that came out this year by Asher and Novasad find no major changes in agricultural outcomes, incomes, or assets due to this road building scheme. So we have it affecting some school outcomes, but not really affecting income or assets. So this paper pushes this further by looking at the impact of this road building scheme on health outcomes, specifically child health outcomes on infant and neonatal mortality. How it does is by creating a unique matched micropanel data set, linking the health outcomes with the road construction in India. This develops a causal estimate by using two different empirical methods. One, using the retrospective birth histories from district level household surveys. A within mother variation in survival of infant is carried out before and after the road construction. So I have historical data on the birth and death of children for each mother in the survey. Using that, I can see the same mother giving birth before and after the road construction and see if that has an effect on household experience of infant or neonatal deaths. And second, I can also invoke a fuzzy regression discontinuity design based on how this program was rolled out. So this program was launched in 2000 to provide all-weather access to unconnected habitations. So habitations are a smaller part in within a particular state and district, and how this program was rolled out was all unconnected habitations with a population of 1,000 people or above were covered in the first 3 years, and then all unconnected habitation with a population of 500 persons and above were to be covered after 2003 until 2007. So the population was based on the 2001 census population, and that was the eligibility criteria. So just by utilizing that cutoff, having villages having 1,000 people or 999 people vis-a-vis 1,001, that provides me a cutoff, and similarly 499 vis-a-vis 501 or above. So the data, this was a huge exercise. PMGSY data was tracked using the online management and monitoring system. This was a pretty corruption-free laying down of roads in India, and it has extensive data on roads built, habitations affected each year, the baseline habitation connectivity status, the sanctioning dates, and the population. However, this is at the habitation level, and my data is at the village level. So habitation goes to village. So this data was then matched to the 2001 census population data to get the village level road construction data. So this data set was provided by Paul Novosad and Sam Asher, and I'm extremely grateful for them to provide me that data. Then I used the health data, which is the district level household survey. This was conducted in 7 and 8. And in DLHS 3, the women of reproductive age are interviewed about the date of birth and death during the last 3 years preceding the survey. So I have a lot of women, and these women have their respective birth histories. And using that, I can create this data set of infant deaths as well as neonatal deaths. Even though the district level household survey is at the village level, it doesn't have village identifiers. So I use the 2001 census data to match the DLHS 3 to the population census to get the village level identifiers. So now that I have both village level data, I then match these two data sets and I get an 81% match. And finally, the sample includes about 122,000 mothers and 151,000 children. So the empirical strategy that is used is the linear probability model. So here I have infant mortality on the left-hand side. This is at the individual level. So the for child I born to mother M in village V at time T, and I'm looking at the effect by the road construction. So whether there was a treatment in village V at time T. I control for child characteristics, I control for district crime trends, and since I am seeing the same mother before and after, I control for the mother fixed effects as well, along with time dummies. The other thing that I want to look at is sex ratio, because there is documented son preference in India, and I see whether there is a change in sex ratio due to this treatment, and so that is the other specification. The next empirical strategy is using a Fuzzy Rdd. So the idea is that even if selection into PMGSY is based on political or economic factors, these should not change discontinuously at the cutoff population levels, and therefore it will provide a causal evidence. So some deviations from the road construction plan are expected, which leads me to use Fuzzy Rd instead of strict Rd. And basically what that is a 2SLS, where the discontinuity becomes an instrumental variable for the treatment status. So briefly, the results, what I find, so this is the linear probability model. I see that in various specifications, some having district fixed effects, some having mother fixed effects, I do not see any impact on both infant and neonatal mortality. We see that there is a possible negative sign, but the magnitudes are very small, and these are not significant at the normal statistical significance levels. Then I go on to Fuzzy Rd. First, I show that it is not that the program was not implemented properly. We see that at the cutoffs, there's a huge jump in the probability of road sanctioning at both 500 and 1,000 population levels. So the program was implemented the way it was meant to be. And there was no gaming of the cutoff. So this is the density of population. We do not see a weird jump at 500 or at 1,000 level. So overall, the road building is taking place as it is supposed to take place. However, when I look at outcomes, I do not see the impact on the outcome. So infant deaths, I see a little bit of jump, but not really much. Same with neonatal deaths. And this is, again, illustrated when I look at the regression results. So in all the specifications having different kinds of controls, village controls, mother-child controls, and flexible population controls, I see insignificant effect across all the specifications. Lastly, sex ratio at birth. Again, it doesn't change the probability of the child being a male or a male child surviving more in both the OLS as well as the fuzzy regression discontinuity design. So therefore, what this study then finds is that the effect of road construction on infant and neonatal mortality using this unique microdata set involving individual level nationwide health data, I see that there is no effect, no statistically significant impact on infant and neonatal mortality or sex ratio at birth, which is kind of in line with the paper by Novosad and Asher, where they find no impact on agricultural output or income or assets. So there are three possible reasons that I can think why we are not seeing the impact. One, it could be because this is the short-term and a short-term analysis. The data is 2007-8, and the road construction started in 2000, so maybe all the benefits have not been realized yet. Second, it is possible that access to healthcare or markets need not necessarily imply a change in healthcare behavior of people, especially financially constrained households. So building roads can get you near to the hospitals, but it may not change the behavior. A part of that is also because we are reducing the time cost, but it does not provide means of access to people to visit these hospitals via the newly roads that are provided to them. So that is all for this, and I'm happy to take any questions.
Thank you, Pallavi. So now we're going to turn to our discussion portion of the session, and we've asked each of the authors to discuss one of the papers. So we'll work in the order of the paper presentations, and I'll ask Pallavi to come on and give her comments and feedback on Tiago's work from Brazil. Thanks, Pallavi. I think you're uploading. Oh, great. Thank you.
Pallavi, I think you're muted.
But we can see your presentation,
Yes.
your PowerPoint.
Okay. Does that help? Hello?
Yes, we can hear you. Great.
Okay. Okay. Thank you. So thank you, Kathleen. So the paper that I'm discussing today is Cash and Care, Conditional Cash Transfers and Birth Outcomes, the paper that was presented by Tiago first. So I'm Pallavi Panda. As you just heard my paper, so I'm an assistant professor of economics at State University of New York, Geneseo. And it was my pleasure to read this paper and to discuss this paper. Okay, so just a quick summary of what this paper did. So this paper looks at the effect of the Bolsa Familia program, the BFP program in Brazil, and the effect of that on infant health and pregnancy outcomes. What this program basically is, it's a cash transfer program. So 9 monthly cash transfers which start to be paid when the eligible woman is identified as pregnant by their system. And what is cool about the program is that it is given out regardless of a pregnancy stage. And so that is a great variation that the authors use in identifying the effect of the program. What they find, the transfer had a positive impact on birth weight and reduced the likelihood of low birth weight significantly. And the mechanism that they discuss is that it reduces the likelihood of delayed prenatal care, though they do not find any effect on the total number of prenatal visits. In terms of contribution, I really like the paper, the way it is written. The program is explained really well. For someone who is not familiar with Brazil, I understood how the paper is set up and what the paper is trying to identify. The identification strategy, as I mentioned, is something that really is clean. So women at different stages of pregnancy were differently exposed to these exogenous income shocks before giving birth, and that leads to different outcomes. The authors spend a lot of time in collecting and matching the data, and so they have great data, individual level data from the BFE payroll, as well as the Ministry of Health. However, they lose some data in matching. Lastly, it is a very big conditional cash transfer program, and this is an important work to show the robust impact of the program with a relatively low cost. In terms of suggestions, the first thing that came to my mind as I started reading the paper was, does this change fertility behavior by the agents? And so this is something that is discussed in their discussion section, that to avoid any confounding for the current empirical strategy, they restrict the control unit to December 2011. But it will be nice to know if this is something that is happening and that can also extend the data set, which will be useful in looking at the impact. Some nitty-gritties in terms of empirical strategy. I missed seeing the municipal level time trends in the specification. And so that is something that may be of concern, as different districts or municipal levels may be evolving differently. And things like the supply side factors, so supply of doctors and nurses, that is something that may be different and differently changing across these municipalities. And so as you are looking at the demand side, we may also think how the supply side interacts for it. So you should, in my opinion, control for these things as looking at the effect of the cash transfer. Similarly, other health programs that may be going on at the same time that may confound the effect. So some kind of fixed effects in that sense may be useful. Event study is something that I think will be important, and currently that is given in the appendix, but I would really like to see that as a part of the main paper, because that establishes that there are no trends. Just a side note that when I look at the event study, it doesn't convince me that there are no pre-trends. Maybe having an F statistic for a before and after is something that may convince people that we are seeing a jump, because we don't see a drastic jump at the December 2011 level. And lastly, Tiago didn't get time to discuss the heterogeneity, but the paper does look at heterogeneity in outcomes. And one thing that stood out to me is, why do women in rural areas do not see the reductions in the likelihood of low birth weight? Because that population is something that I would expect to benefit from a cash inflow. So if we are saying that the cash transfer is by itself that is helping in improving health outcomes, why is it that the people who are the most disadvantaged not seeing the effects as much? So that is my brief discussion. I'm happy to discuss this with you further, Tiago, if you like.
Great. Thank you, Pallavi. Now we'll ask Tiago to comment on Hamadou's work in Senegal. Tiago.
Okay, so first, I think the paper is really nice. So I think it's very important to explore the effects of extreme rainfall precipitation in rural areas, like when there's the poor population. So I really like the data set the HDSS. It's really amazing for developing country. We know, like we are both from developing countries, we know how hard it is to find like rich data, administrative data. And I really like also that you explore the causes of death to try to understand more or less the mechanism and the channels from which the rainfall would impact mortality. Uh, Also to look at the difference between the two seasons, the rainy season vis-a-vis the dry season. I think this could shed light on the disease environmental effect versus the income nutrition effect. And finally, also, I really like that you try to use like a lot of different specifications, changing the controls, and the results, they remain robust. So I think you did a very good job in trying to convince us that you are estimating like a robust effect. And regarding some improvements and suggestions, I think at first the literature review section is too extensive. So I think you should put less details on trying to explain all the papers and focusing on framing more or less the overall findings of the papers and how you are adding to this literature, because I really think you are adding a lot to the literature. So focus more on what you're doing and try to explain less with less details the other papers. Also, something that I thought, I don't know if you will have like the data available to do that, but you could test the different scenarios. So the disease environment versus the income nutrition by looking, for example, if rainfall increases economic activity during the dry season, but for example, it could not have an effect on the wet season. So by looking like rainfall, the effect of rainfall in economic outcomes in the two seasons, maybe you could have more ideas about what is going on to test these two different hypotheses. Also, I think it would be interesting maybe to look at in utero exposure, uh, like uh, like the paper from Soares and Rocha from Brazil that you cite, and maybe, I don't know if you have the data, but maybe other birth outcomes and also mortality for different age groups. And the last 2 points is that maybe you could also try a different specification, setting a threshold for like very high rainfall precipitation or very low rainfall precipitation. So try to see like if extreme events, they have different impacts. Uh, and finally, the last thing is that I think it's important to try to discuss. So you are doing an OLS estimation. I think you are doing like a very good job, but I think it's important to discuss potential bias in your OLS estimation. And for example, correlation between rainfall and infrastructure, maybe places that has higher levels of rainfall, they are also less populated, they have less infrastructure, and maybe this is driving the results on mortality and not the rainfall per se. But overall, I think it's a very nice paper and there's much to work and make it even better.
Thank you, Tiago. And finally, Hamadou, if you would like to make your comments on Pallavi's work from India.
Yes, exactly. So thank you so much, and I'm so pleased to attend this session. And now I'm going to discuss the paper, Road and Health Outcome in Rural India. So this paper, this paper is a very nice paper, and now I have some ideas about the outcome, because in this paper you use infant and also neonatal mortality and sex ratio, but you find no effect on of road on the infant and neonatal mortality. So maybe you will find an effect if you change the outcome. So I'm wondering if you have data on weight for age and ratio, donc the weight for age ratio, or or if you have data on the age for age ratio, which has widely used in the literature, such as a nutritional and status of the child. So maybe you will find an impact if you change the outcome. And also road may improve access to market and also increase a large choice of food, which could improve the nutrition of child. So you will maybe find an effect if you change the outcome. And my second um, comment is about the data. And in this paper, you use a panel of mothers. And now I'm wondering if I well understood, you keep only mothers who have only mothers who have at least two live births. So if it is the case, maybe it is a sample selection issues. So I'm wondering how do you will how do you deal with this issue? And also in this paper, the different link, and in this paper, the different in this paper, the different link and between roads and also infant mortality are not so are not examined it. And also I'm wondering if you have some data limitation because you don't examine the different pathways between rainfall and infant mortality. So I'm wondering if you have some data limitation. This is why you do not examine the different pathways between the two variables. And so my last question is about your empirical strategy. In this paper, you use a regression discontinuity design. So I'm wondering, why do you prefer to use a regression discontinuity design rather than an experimental variable approach, which is widely used in the literature, such as historical roots or the straight line distance? So I'm wondering the choice about the empirical strategy and why you prefer to use the regression discontinuity design rather than the IV, which is widely used in the economic literature. So I think that is all. And this paper is it is a very nice paper, and thank you for the presentation.
Thank you, Hamadou. Now, very quickly, would any of the authors like to make any quick responses to the discussants? We only I think if my math serves, we have. Let me just double check on the time. Yeah, we have time for you to make some comments on the discussion. Tiago, anything you'd like to say?
Yes, I would like to thank Pallavi for the comments. So the first point about the effect of the program on fertility, I think that's very important, and it will be very interesting to see if indeed this transfer would induce women to get pregnant to receive the transfer. I haven't focused on this because I didn't want to undermine the exogeneity of the empirical strategy, but this is really important to understand. About the time trends, the thing is that in the empirical strategy, I'm comparing like very similar women with very similar characteristics, but the only difference would be that they were at different stages of pregnancy. So I'm also controlling for where do they live, some characteristics. So the specification, the empirical strategy uses the variation at the individual level. I'm not using like a municipality level empirical strategy. So I haven't thought about using municipality time trends because it's regardless of like the municipalities, just beneficiaries of the program. And I don't know if this makes sense for you. Also, the other points I really think it's useful to dig in. So look at the supply of doctors and other health programs. I'm looking at a specific time. So it's only at the introduction at the program. So comparing mothers at December 2011 at different stages. So I don't think like the supply of doctors would change the results, but I think it's interesting to see also. And yes, for the also explore more the mechanism why, for example, women in rural areas they don't have a reduction in low birth weight, for example. I think that's important to dig into more. So I'd like to thank you for the comments, and I hope I can address some of the questions in the future.
Thank you, Tiago. And Hamadou, would you like to make any comments on your paper and discussion?
So thank you, Chago. Thank you for this discussion. And also, I think after I will look at the in utero outcome, and also all the best outcome, because here in this first draft I focus only on the post-neonatal and also the child mortality rate, and also I will analyze the impact of rainfall on the economic activities. All but here I have only data on the agriculture output, but I don't have data on the revenue. So this is the reason why I don't examine the impact of rainfall on the economic activity. And also I will deeply analyze the bias about the empirical strategy, because maybe there is some bias. And so thank you so much for your comment, and thank you. This is all.
Great, thank you. And finally, let's go back to India, Pallavi.
Thank you, Hamidou, for your comments. And I agree that there are other outcomes that need to be seen. So I am in the process of doing the weight for height and the height for age Z-scores and all of that. So that should be something that will be added to the paper. The only concern that I have with those outcomes is that these are not historical. So I can't control for the mother fixed effects because it is at the time of survey and it's not something that goes back historically. And so that is something that limits the pathway as well as the other health outcome analysis. And that is why it's not there in the first draft of the paper. And in terms of the mother having two births, so sample selection, I do run some kind of statistics, kind of checking whether these samples are different, whether mother with 2+ births are different from mother having one birth or not having any birth. I do not find any significant differences in there. And lastly, your point about the Fuzzy Rdd, why do I use that is because I have this quasi-random program which I am utilizing. So when historically people have used let's say the railway construction before, or straight line distance, that is they are using the history as kind of an instrument to today. But what this paper does is it uses the natural experiment that is carried out today. And why Fuzzy Rdd is, it's fuzzy because the experiment is such that so you decide administratively to do something, but it may not be perfect. And so that is why it leads to a fuzzy instead of a strict RD design. So that is something that I use. And using the LPM strategy, where I use the mother fixed effects, I show that the results are similar with either of the empirical strategies. So, but thank you for your comments, and I am obviously going to look at the child health outcomes and the pathways as well. Thank you.
Thank you. Marcelo, I think we had a question in the Q&A.
That's right. There is a question on Q&A, and I would like to make also one question. So the question is for Pallavi. She already answered, but let's put in for everyone. Regarding the third paper by Panda, who is the infant mortality rate calculated This is not entirely clear to me from the paper. Are only observations fully exposed to the risk of dying? Example, infant mortality rate included. Otherwise, the construction time of the roads and the infant mortality rate are potentially mismatched. And from my perspective, you would need to incorporate a survival model if the data should be facilitated. So, Pallavi.
Thank you for the question. So how this paper does is that it doesn't take an infant mortality rate at the India level. What it does is it takes the household experience of child death. And so after 2000, so let's say there's a mother who gives birth before and after 2000. So after 2000, there was a road, but before 2000, there wasn't. And there's a cutoff. So if she belongs to a village which has a population of 1,000 or more, she's exposed. If she is not in that kind of village, she's not exposed. So that is the variation that I am using.
Okay, excellent. I have one question. I don't know if it's I'm allowed to do that, but I have a question for Thiago.
Marcelo, you have the power of the microphone. You could do anything you want.
I just did a coup here, okay? It took power. So, question for Thiago, take advantage of Hamadou and Pallavi points, in their papers. The period around 2011 onwards, there was a severe drought, no rain in the northeast of Brazil, which is very intensive in terms of Bolsa Família. And so this is a big shock, it's random, take advantage of Hamadou type of points. And also there was a program on cisterns, which are water reservoir that can be allocated. So maybe, a direction for a new paper. I know you are fond of climate and things like that these days. And and I have a suggestion for the title of the paper, which would be Cash, Care, Climate, and Cisterns. Okay. So just to add in your framework, these rainfall data, which you mentioned some papers in Brazil from Soares and Rudi Rocha. So I think it's observable.
Thanks, Marcelo. I think that's a great suggestion. I wrote on the chat that I think that's a really great idea, and I think it could add to the paper also by, like, I was arguing that the results for birth weight, they are a lower bound because there is this survival rate could change, and also like the drought can also make the results to be an even lower bound, because I find positive effects even without taking into account the drought. So I think,
and it takes to the Pallavi point on the rural area that we didn't see any effect there. Maybe because it was really a very bad
relation.
weather.
I think it's very interesting to explore this. Could add a lot to the work. Thank you.
I put a question in the chat to Hamadou about birth order. I don't know if you've seen it. I was wondering if you've looked at birth order, particularly on the gender results, because I wonder if the larger impact on girl children is mainly concentrated among fourth or fifth higher birth order children. And if so, if we see fertility reductions coming out of some of the efforts we're seeing some governments in the region take on expanded access to family planning, would we then expect the girl disadvantage to shrink, perhaps?
So, yes, exactly. It's a good point. So here in this paper, I compute the post-neonatal mortality without taking into account the birth without taking into account the birth order. So exactly, it's a good point, and I will examine this point later. in the next draft.
Great. One might make the same point about the other two papers also. I'm not sure. I didn't catch if either of you, Pallavi, do you look at birth order?
You make a great point because there is a huge literature in India on the birth order and female and interaction between them, how that affects. I haven't looked at the birth order yet, but yeah, that I am going to do that.
And Tiago, in your
So your comments, it's also a good suggestion for my paper because I don't control for birth order.
Tiago, do you mind, Marcella, if I ask another question? If we know? I don't know if you can unpack this. I'm sorry if I missed it in the paper, but how might one differentiate the impact of the conditionality from the cash? Is there any way to unpack that with the data that you have and given that the program is all conditional?
So I cannot disentangle the impacts clearly. What I can say is that they are both important. So I look at prenatal care and I see that there is an effect in reducing delayed prenatal care. So if I didn't see any effect, I could have said, oh, it seems to be only the cash. But from my results, the only thing that I can say is like both cash and care, they are very important, but I cannot disentangle the impacts.
Can you say anything about the potential cost of the conditionality? I mean, in terms of thinking of the cost benefit of establishing a cash transfer program that comes with conditionalities, is it worth the cost?
Yes, I think that's something that I can build on to because it's everything from the public healthcare system. So I imagine the cost it's not so high because it's already settled. So it's just like a couple of more women going there. But I can try to get the numbers. I think this could add to like try to do a cost benefit analysis. Thanks for the suggestion. I think this would make the argument clearer and
just to try to build just one on Kathleen's question, which is, I don't remember exactly, but there was the phasing in, this BVG was the introduction of the complementation, of income towards the poverty line. So it's variable. And this was not introduced. It was first introduced in this benefit, and then it was introduced in other benefits. So maybe the timing of the introduction, I don't know how we use, but you have, not only a different time of exposure, but also different cash, transfers, the size of the transfers may be variable. So across time. So maybe there is some sort of variation there.
yeah, sure.
Great. Any other comments that I offer to the panel? And I'll make a suggestion to Hamadou, since we're talking about cash transfers and conditionality in Brazil. I think Senegal, if not least under COVID, is probably expanding their own cash transfer program. So maybe there are some ideas you can replicate some of this work that Tiago has done in Brazil in the cash transfer case in Senegal.
Exactly.
So I wish you all luck with your papers and moving them forward. I think this is a great addition to what we know about what contributes to human development outcomes and the differentiation both by socioeconomic status and gender, and the extent to which you can unpack some of those pathways and identify particular types of households where these impacts are greater, and what future policy agendas, be it cash transfer or expanded family planning and efforts to address high fertility, might mean for those socioeconomically differentiated impacts, I think would be great additions to your work. I think we're coming in at just a few seconds under time, which is just perfect. I think this is the last session of the day one of the workshop. So we look forward to seeing you all tomorrow, bright and early. We'll have a plenary session in the middle of the day talking about, well, middle of your day, whatever that means for your time zone, to talk about COVID, the COVID research agenda, and of course, we have a number of sessions tomorrow. So again, thanks for joining.
Just one
Huh?
question.
Yep.
Do we have the meet the authors?
We're supposed to have thank you for reminding. I mentioned at the beginning, we have a meet the author opportunity after this session. So I encourage you all to click on the link. It's a different Zoom link to have more informal discussion. And for participants, it's an opportunity for you to bring up your own work. So for those of you looking at child health and doing research and papers on that topic, please come to the Meet the Author, advertise your work. Let's share work with each other, even if it's still in the pipeline. So we'll see you over at the other Zoom, I hope. Thanks, everyone. Thanks, Tiago, Pallavi, Hamadou, Marcelo.
Bye-bye.
Thank you. Bye.
Thank you all. Thank you.